Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And today we are going to dive into another 3 sets of Vivas. So before we dive, Maddie, how's life and how's things going?
Yeah, pretty good. Can't complain. Work's all right. And then I'm going to go to New Zealand soon to go skiing. Yeah, that's good. How about you?
Yeah, no, I think I'm just busy with fellowship and primary exams. But yeah, there is a plan for holidays in second half. So that's the borders are open now. So yeah, we're looking forward to having some holidays. So wish you have a great holiday and come back and do more episodes of this podcast. So Maddie, let's start with our first Viva. So we got 26-year-old male who remains ventilated 1 week after motor vehicle accident, in which he sustained severe intra-abdominal and traumatic brain injuries, as well as multiple fractures. He underwent an immediate trauma laparotomy and required a splenectomy, along with repair of bowel perforation. He has had a persistent fever since admission and has received a course of tazocine. He's currently receiving a low-dose noradrenaline along with TPN via non-tunneled CVC. He has a history of intravenous drug usage. So can you please give a differential diagnosis for the fever in this patient?
Sure. So there's multiple causes for fever in this patient, which can be divided into infectious and non-infectious causes. So in terms of infectious, there are multiple potential causes, but my concern would be regarding potential multi-resistant organisms or a fungal infection, given that he's had ongoing fevers despite a course of tazocine, which is quite broad spectrum. So things that tazocine might not cover include the escapum organisms, multi-resistant gram-negative organisms, things like MRSA or VRE, fungal infections, or certain penicillin-resistant organisms. The other issue from an infective point of view could be a lack of or reduced penetration or an inadequate dose despite bacterial sensitivity. So potential infections that would fall into this category would include certain intra-abdominal collections like abscesses, meningitis, and infective endocarditis. And in terms of for infectious causes, the location in this patient may be multiple. So it could be a central nervous system infection, it could be a sinusitis of his NG tube, it could be skin or line source, ventilator-acquired pneumonia, given that he's been intubated, any intra-abdominal source, given that he has had a laparotomy, joint infections, infective endocarditis, given his history of IV drug use or a UTI. And we also have to consider that he's asplenic, so he's at risk of infection by encapsulated organisms, and need to consider whether he was on any prophylaxis after this course of tazocine was given. In terms of non-infectious causes, these are also several. So common non-infectious causes in this patient could be drug-related causes, such as withdrawal from drug or alcohol, drug fevers, such as from antibiotics itself, or serotonin syndrome, especially if there was an interaction with multiple serotonergic agents. Inflammatory causes such as acalculous cholecystitis, given that it sounds like he's been critically ill over the last week, seizures secondary to his head injury, an aspiration pneumonitis or pancreatitis, transfusion related if he had a transfusion of blood products given his trauma, vascular causes such as a DVT or PE, given that he's had a stay of a week and may not have been on any DVT prophylaxis, ischemic bowel as a complication of his initial laparotomy, and intracranial hemorrhage, which might be a worsening of his initial injury. Endocrinological causes could be things like overfeeding from a nutrition standpoint.
Yeah, that's correct. I guess often one of the common mistakes that most of the candidates make, that they just give a shopping list of causes of fever, which can be very simple trap to fall into, which is infectious and non-infectious. But what examiners are looking at is the most relevant causes to that particular patient. So try to prioritize the causes that are most relevant to this patient, as you did. And again, that will give you more marks rather than just giving a list of all the causes for fever. Now, in order to assess this patient, what will be your approach?
So assessment, as I guess with all of these kind of questions, would involve a thorough history examination and targeted investigations in order to determine the cause of this patient's fever and thereby to help progress their management. So an assessment would involve history, exam, and investigations. The history would be trauma-related. So this would specifically involve the extent of his injuries and the treatment received, and any recent imaging or progress imaging, especially of his head and abdomen that he might have received. History about the fever itself, so any recent microbiological tests, the age of his current central lines, the trend of the fever and the vasopressor requirement. He's on low-dose noradrenaline currently, but has that been increasing or decreasing? The dates of his antimicrobial treatment, whether he had any post-splenectomy prophylaxis, and any localizing symptoms for this fever that might point to an infectious source, as well as thinking about other culprit medications and transfusions given in their time course. Also be important to know about his background, so details about his intravenous drug use, whether it was still active and whether he was on anything like methadone, and any other drug or alcohol use. And then his global trajectory in ICU, such as his ventilator requirements, his pressor requirements, organ function, screening, Dopplers, and nutrition, just to kind of think about either identifying the source as well as any non-infectious cause of the fever. Examination would also be targeted at his vital signs and any localizing signs of fever, such as meningism, his line sites, signs of DVT, and his respiratory exam and sputum production, as well as his abdomen, whether it's benign or has any signs of infection. And investigations would be bedside bloods and imaging. So bedside would involve the ABG to look at his metabolic parameters and things like his lactate for ischemic bowel, an ECG, which might show signs of things like right heart strain or tachycardia, and an echo, which might be first line for looking at something like infective endocarditis, and then considering things like a toe if there was a high index of suspicion. Bloods would involve a full septic screen of peripheral and central cultures, sputum, urine culture, looking at his organ function, so his renal function with UECs and his liver function with LFTs, a full blood count to look at his inflammatory response and his hemoglobin, and consider things like inflammatory markers such as procalcitonin or CRP, which might not be useful in isolation but would be useful as a trend potentially, and thinking about lipase for pancreatitis. Other potential more specific blood tests could include things like the serum galactomannan if thinking about fungal infections. And then imaging would involve generally a baseline chest X-ray to look at his lung field, and considering things like a CT pan scan or a toe, depending on your findings of the above assessment. Further specific investigation would be guided by your history and examination, but it could potentially include an LP, an ultrasound of the abdomen, and a bronchoscopy, and thinking of potential more specific tests like fungal cultures.
Yeah, that's great. Again, what you did well there was when you outline investigation, every time you say one investigation, then you followed by the rationale of that investigation. And that's really important. Like, as you mentioned, ECG looking for tachycardia and right ventricular strain. So always mention the investigation, but also specify what you're looking for when you're ordering that investigation. Now, as you mentioned, you perform the blood cultures and the blood culture result come back positive for Candida glabrata. Can you please outline your specific management in view of this new information?
Yeah, so the specific management would involve treating the candidemia itself, identifying the source if possible, and evaluating for complications and treating these. So in terms of the candidemia, the first line is generally an echinocandin for Candida glabrata, which is usually an imidulofungin 200 milligrams IV for the first dose and 100 milligrams daily. And this is because the species demonstrates a high resistance to azoles. Depending on the index of suspicion and the other characteristics, some people even treat with something like amphotericin to begin with. We might be able to de-escalate to fluconazole if this is found to be a susceptible species, but generally first line is starting with a non-fluconazole. He'll also need daily blood cultures until culture results are negative. And then in terms of the duration of treatment, it's usually for at least 14 days after the culture results are negative if there are no metastatic complications of the infection. So metastatic complications such as liver abscess would require 4 to 6 weeks of therapy. In terms of identifying the source, so I'd be checking the findings of investigations, including peripheral and central cultures, recent imaging, sputum and urine cultures, and low threshold for repeat imaging if there are concerns regarding metastatic infection. I'd most likely be changing the central line and sending the previous CVC tip for culture and take new blood cultures with insertion of CVC, but this will obviously depend on a case-by-case basis, as in some people the risk of changing the line might be greater. and then evaluating for complications and treating these. So the standard screening would involve a fundoscopic examination by the ophthalmologist to look for endophthalmitis and to look for endocarditis with an echo, which is often initially transthoracic but can then progress to a toe if there's high index of suspicion. Other potential complications can include arthritis, pulmonary candidiasis, and hepatic and splenic abscesses. Obviously not splenic abscess in this patient who's had a splenectomy, but we would look at for signs of have a high index of suspicion. So look for any signs of inflamed joints, any complication on CT, such as CT signs like a halo sign in the lungs, and any signs of hepatic abscesses on CT.
Great. And this patient has got Candida glabrata and not Candida albicans. So what are the risk factors for invasive non-albicans candidiasis?
So the risk factors: prolonged ICU stay, exposure to broad spectrum antibiotics, exposure to fluconazole, central venous catheter insertion, TPN, diabetes, renal failure, repeated abdominal surgery, and immunosuppression such as malignancy or high-dose steroid use or stem cell or organ transplant. So this patient has quite a few of those risk factors.
Yeah, that's correct. And I guess obviously this patient has got blood culture positive with Candida glabrata, so you will start antifungal treatment. However, sometimes you end up in scenario where blood culture is negative and patient stayed in ICU for prolonged period of time and has got all these risk factors. So what's the role of empirical antifungal treatment in the critically ill patients?
So this is tricky, as the role of empirical antifungal treatment in the ICU population hasn't been fully elucidated, and there's still some debate. But the evidence, such as the Empiricus trial, which was in 2016, has shown no significant benefit in empirical antifungal therapy for patient-centered outcomes. So this was a RCT of 260 mechanically ventilated patients with at least one organ failure and new ICU-acquired sepsis of unknown origin. And they were treated with empiric micafungin or placebo for 2 weeks. And there was no statistical difference in 28-day infection-free survival. But the micafungin group had lower incidence of new proven invasive fungal infection. But there are multiple unanswered questions in this field in regards to which patient subgroups may in fact benefit from commencement of empiric antifungal therapy, what are the criteria for commencement, and what is the optimal timing for commencement. So the main guideline that we have as the Australian Society for Infectious Diseases consensus guideline, which recommends empiric antifungal therapy for clinically unstable hematology patients. But this is like in clinical practice, I've rarely commenced empiric antifungal therapy except in patients who have multiple risk factors for invasive candidiasis and have a high risk event, such as if they've had an esophageal rupture or who have multiple risk factors and a deteriorating clinical state despite appropriate antibiotic therapy. I don't know what you normally do in your practice, Swapnil.
Yeah, so it's, as you mentioned, it's case by case basis because the evidence for empirical antifungal therapy is not really that strong. Now, often we do get sometimes Candida albicans growing in sputum or urine, which is most likely the commensal. Having said that, when you look at some of the long stay patients who has got abdominal surgery and got on TPN and got all the risk factors present, and even they grow Candida in 1 or 2 sites, and they're still febrile, they're still not growing any bacteria. In that case, you bite the bullet and start antifungal treatment in consultation with your ID colleagues. And often you de-escalate if either there is no response to antifungal treatment or patient is getting better without it. So I guess that's been the approach, but it's always going to be a case by case basis rather than this blanket rule of day 14, day 15 in ICU on TPN start antifungal treatment. And always the source control is the most important thing in these patients. So, yeah.
I was going to ask, have you ever used the beta or measure the beta D glucan level? Like, I know we've learned about it theoretically, but I don't know if it's available yet in Australia.
No, you're right. We don't measure beta to glucan level. We do measure galactomannan level, and especially that has become more prevalent practice after the COVID-19 pandemic because these patients were heavily immunosuppressed and they were at risk of aspergillus infection. So serum galactomannan has become a bit more trendy now before we commence anti-aspergillus treatment, but not with the beta to glucan.
I think that's used overseas a bit, or in research papers anyway. That beta-D glucan, but I haven't actually seen it ever used here.
No, I must say that's a good thing in Australia, because I think we are very quite strict about our usage of antibiotics or antifungal, and that actually helped us to prevent a lot of resistance to antifungal, because once you start developing antifungal resistance, it's really difficult to treat further infections. So yeah, so that's a good discussion actually, and I think candidates need to be prepared to own your choice, why you are going to start or why you are not going to start empirical antifungal treatment in that particular patient. So let's move on to the next scenario. You got 75-year-old female who is previously fit and well, admitted with hypoxemic respiratory failure due to community-acquired pneumonia. Now, she has developed multi-organ failure over the first 3 days of her stay in intensive care and requiring extensive support. Her cardiorespiratory status has gradually improved, but now she remains ventilatory dependent at day 10. What might be the specific barriers to her weaning from ventilator, and how might you manage those barriers?
I used a system approach for these, and I think there are multiple potential specific barriers in this patient, which include neurological, metabolic, gastrointestinal, cardiac, and respiratory. In terms of neurological, they can be divided or subdivided into neuropsychiatric and decreased neuromuscular capacity. So from a neuropsychiatric point of view, these include things like delirium, anxiety, and pain. And ways to manage this are by minimizing sedation and trying to rationalize the pharmacological agents to minimize side effects, to adequately treat pain, optimize the sleep-wake cycle, which generally involves non-pharmacological management but can sometimes involve some pharmacological management, and to screen and treat for delirium. In terms of decreased neuromuscular capacity, this includes things like critical illness, polymyoneuropathy, and the ways to manage this would be to make sure that this patient has adequate nutrition, regular physiotherapy, trying to avoid things that we know increase the risk of critical illness neuropathy, so avoiding steroids and neuromuscular or prolonged neuromuscular blockade, and to optimize her electrolytes. In terms of metabolic and renal causes, these can be subdivided into increased demand, metabolic acidosis, and renal failure. So in terms of increased demand, conditions that can cause increased demand would be hypoxemia, fever, and sepsis, and severe anemia. So management would involve treating any, or like a high index of suspicion for infection and very fastidious screening for infections and treating these if present, using paracetamol, fever, correcting anemia, and treating any other potential causes of hyperdynamic circulation. Metabolic acidosis, there's multiple potential underlying causes for this, but in terms of managing it, it'd be to treat these causes. So whether it be from a ketoacidosis or a lactic acidosis or renal failure itself. And then for renal failure, trying to reduce any nephrotoxic agents, optimize fluid balance, and considering whether this patient does require any dialysis. In terms of gastrointestinal causes that may impact on her weaning from the ventilator, this would be subdivided into abdominal distension and overfeeding. So abdominal distension, to optimize this, it'd involve aperients, potential nasogastric decompression and physiotherapy. And overfeeding would be to, once again, optimize her nutrition, potentially decrease carbohydrate load and optimize the electrolytes. Cardiovascular causes could be new ischemia, arrhythmias, or dysfunction, or fluid overload. So from a new ischemia or new cardiac pathology point of view, it'd be to assess, do a comprehensive examination and diagnose using things like an ECG, potential troponin and echo, and a cath if indicated, and then treating this myocardial dysfunction. So whether that's by anticoagulation, antiplatelet agents, reperfusion, or optimizing the rhythm or rate. And fluid overload would be optimizing the fluid balance, which would involve things like diuretics, concentrated feed, drain effusions, and consider refractory fluid overload. And respiratory causes would be things that increase the resistance or decrease the compliance. So increased resistance would be things like bronchospasm, secretions, the tube itself. So considering a tracheostomy for a ventilatory wean, making sure the circuit's humidified and that this patient has adequate physio, bronchodilators, and considering a bronchoscopy for removal of secretions. And then decreased compliance, it'd be to manage this would be to ensure that the patient is on appropriate ventilator settings, make sure that we're treating any potential lung disease that's contributing to the decreased compliance, and ensuring that, head of bed is up and she's in an adequate position.
Yeah, I guess again, a failure to wean is a very commonly asked template, either in Viva or in hot case. So I guess having that kind of systematic approach is very useful and handy. And then you modify obviously based on the context that you receive during the exam. Now, can you please list the complications of prolonged invasive mechanical ventilation?
So the complications include anatomical, neurological infections, GIT, and some other complications. So anatomical complications include laryngeal or tracheal injury from the tube itself, bronchial injury from suctioning, laryngeal or tracheal stenosis, or tracheomalacia with prolonged intubation. CNS complications include sleep disturbance, neuropsychiatric complications such as PTSD, depression and anxiety, and neuromuscular complications such as muscle wasting and critical illness polymyoneuropathy. Infective complications include the obvious ventilator-associated pneumonia, but also line infections because requirement for prolonged sedation and invasive lines, sinusitis because they often need NG tubes, and colonization with multi-resistant organisms, as we often see in patients who are long stays in ICU. Gastrointestinal complications include swallowing dysfunction and mucosal ulceration, and some of the other patients include DVTs from prolonged immobility and pressure areas.
Thanks, Maddie. So let's move on to the third Viva for today. A 68-year-old male who is 2 days post aortic valve replacement for aortic stenosis with good LV function. Now, his recovery was uneventful other than a junctional bradycardia of 40 beats per minute, which required VVI pacing at 80 beats per minute via epicardial RV wire placed at the time of surgery. Now, his nurse asked you to have a look at the patient as his BP started falling. He is on nasal prongs, remains conscious, and his bedside monitor shows pacemaker spikes with no corresponding QRS complexes. How would you approach this problem?
So this patient has a pacemaker that's failing to capture, which is potentially a life-threatening situation, although currently the patient's level of consciousness and respiratory function seem to be stable. Ongoing management will depend on whether he is hemodynamically stable or unstable. So this would require a rapid assessment as to his vital signs, level of consciousness, his blood pressure, and signs of end organ perfusion. So if he's unstable, it'd be to call for help, which would involve the remaining of the ICU team, potentially cardiothoracics, and ensuring the arrest trolley and the airway trolley are present. And it'd be concurrent assessment and resuscitation. So evaluating the cause of the falling blood pressure. So is it just a rhythm issue of the pacemaker? So looking at his current heart rate, blood pressure, respiratory rate, SATs, and their trajectory, as well as temperature, whether his chest drains are still in situ and what their output has been like, to look for other causes of this low blood pressure, an ECG and an ABG to look at his metabolic parameters and lactate. Consider it an echo, but often in this urgent situation, that's sometimes a bit down the track. Chest X-ray and looking at his electrolytes, because that might also be impacting on his failure to capture, and his current medications that might be impacting. And then it'd be to also optimize his rhythm. So apply transcutaneous pads, and so we can pace externally if required. But this would obviously require the patient to be sedated first, and also, if that's the case, be prepared for intubation with the sedation, and to troubleshoot the pacemaker. So it can try either an emergency mode by increasing the output to maximum, or placing the pacing on DDD if he also has atrial leads, or VOO, checking all the leads, connections and batteries and replacing them if faulty. Other things, if these immediate management options don't work, is to try reversing the polarity of the leads, or converting the bipolar circuit to a unipolar circuit with a cutaneous pacing stitch, and considering pharmacotherapy such as isoprenolone to try and increase his heart rate if it's just a rhythm issue and you're not able to adequately pace him. Other options are, if the PA sheath is still in situ, you can potentially float a pacing swan or a temporary pacing wire, but this is often when the patient is a little bit more stable and you need them to be to have an adequate cardiac output, because often it can be a bit of a fiddly process. And then to optimize any other contributing pathologies such as his electrolytes. We also want to optimize hemodynamics and treat any specific cause. So if it's not purely a rhythm issue, then you might consider things like fluid or blood if he's bleeding, vasopressors or inotropes if there's signs of a low cardiac output state that's intrinsic from an intrinsic contractility point of view. But this would depend on the findings of your assessment, and it's less likely in this patient given that he's had a good LV ejection fraction previously and a pretty uneventful post-op course. If the patient was stable, we'd be looking to evaluate and treat potential other causes of falling blood pressure as identified and discussed earlier, and then to optimize his pacing, but you have a bit more time on your hands. So looking at what the patient's underlying rhythm is and if it is sufficient to maintain adequate cardiac output. So that is, does the patient still require pacing in the first place? Checking all the leads, connections, batteries of the pacemaker and replacing if faulty, and then we'd increase the pacemaker output until capture is achieved. So if this isn't able to be achieved and the patient still requires pacing, then we can try once again to reverse polarity, notify cardiothoracics, apply transcutaneous pads and consider transvenous pacing or pharmacotherapy such as isoprenolone. But if there's a rapidly escalating capture threshold, but the patient is still able to be paced adequately, then we should still apply pads and notify cardiothoracics because we need to have a contingency plan for if the pacemaker is failing and it's showing signs, and it is showing signs of that if there's a rapidly escalating capture threshold. We also want to check some of the other pacing settings, so checking the sensitivity and then optimizing his temperature and his electrolytes.
That's right. And again, that the entire approach depends on how stable your patient is. And I guess basic stuff to think about is call for help, transcutaneous spacing, pharmacotherapy, and obviously then thinking about the rescue strategies like temporary transvenous spacing. So I guess what are the causes of failure to capture in this patient?
Usually pacemaker issues, but they can also be patient issues. So pacemaker issues would be the wire's malpositioned or is moved, or there's the wire has fibrin deposition, which does happen over time. And as people would have seen with post-cardiothoracic patients, the temporary or the epicardial wires do get less able to pace over time. But it could also be a patient issue. So it could be any significant acid-base abnormality if the patient's very acidotic, any significant electrolyte abnormality, especially hypo or hyperkalemia or hyperglycemia, and drugs. So if they're also getting concurrent beta blockade or calcium antagonists.
Thanks, Maddie. That's the end of our today's 3 Vivas. I assume that you don't have any joke to end this podcast.
Why would you assume that?
Sometimes you develop bad habits.
No, I've got one.
Okay, fire.
Okay. So why does Candida get invited to all the parties?
Because it's fun.
Oh, you're really close. Because he's a fun guy.
Oh, yay.
I'll give you like half.
Oh, yeah, sure. Thank you. At least I scored something.
You did it.
But that was the easy one, to be honest.
I know it was.
Yeah. So anyways, that's good. That's good to have some points scored this time. So thanks, Maddie. So that's the end of our today's podcast. We'll be back in months' time with another episode. So till then, enjoy your time and we'll see you next time.
Thanks for listening. See you next time.